So first, who here has Parkinson's? Okay. Who here is a caregiver for somebody living with Parkinson's? And who here is just somebody interested in learning more about the disease? Perfect. So we've got a lot of people in here. So we're going to cover a lot of great stuff today. As Beth mentioned, my name is Dr. Beth, okay? I am a board-certified specialist in geriatric physical therapy. So I spend my day working with older adults, and about 40 to 50% of the people that we see on a regular basis are people living with Parkinson's disease. It's been one of my specialties since 2004, so I've been practicing about it for about 20 years now. So those are my two daughters, Harriet and Estelle. The picture's a little outdated because they are now 9 and 10, and this is back when they were in preschool and kindergarten. But for the 100th day of school, they are asked to dress up like 100-year-olds. And I love sharing this picture because it's just fun. So they wanted gray hair. And yes, graying hair is a normal part of the aging process. Great, so I spray painted their hair. They wanted to wear glasses, and yes, glasses are a normal, changes in vision are a normal part of the aging process. I have my first pair of progressives, and I'm still getting used to them. So bear with me as I move my head all around to try to see my slides today. But we took some old sunglasses, we popped out the lenses, and voila, they had glasses. They wanted to wear clothing that made them feel like a granny, so they chose a dress with a cardigan and pearls. And then they wanted to be cool grannies, so they asked to wear hot pink lipstick, to which I said yes. Do you want me to use it? Yeah. We were testing. Is that on?
Oh, no, turn up. There you go.
Okay. Yep. Oh, yeah, that is better. Thank you.
Turn off those lights.
Oh, and turn off the lights up here? Good. Is this better? I think this probably sounds better.
Yeah, it's covered.
So then, though, my oldest daughter, Estelle, who was only 7 years old at the time, she asked me if she could have a cane to complete her outfit. Because she assumed by the time she was 100 years old, she was going to need a cane to walk. So I think it's just interesting to share that story, that children as young as 4 years old, according to the World Health Organization, already have negative concepts and beliefs about what it means to age. And I share this story in every single talk that I give, no matter the topic, just to kind of point out that you too probably have some preconceived notions about what your aging journey is going to look like, what is appropriate, what is possible, especially when I talk about high-intensity training today for folks living with Parkinson's. A lot of people, their initial reaction is, oh, that can't be right, okay? But a lot of it is rooted in this idea of ageism, that as you get older, you become weak and frail and feeble-minded, and you can't make your own decisions, and you're going to lose your independence and become dependent on others. Okay, so it's just something I like to kind of start with when I give my presentations. But today we're really going to be focusing on Parkinson's. We're going to talk about why exercise is so important to help manage a Parkinson's disease long-term, to not only slow the progression of the disease, but help to maintain independence and quality of life longer. So, for those of you who don't know much about Parkinson's, it is a progressive neurological disorder. Well, what does that mean? It simply means that the longer you have it, the worse it's going to get. So it's going to progress over time. There is currently no cure for Parkinson's. So there are a lot of people that do medications and do exercise and have surgeries, but there is no cure for it. So the treatment goal is really to slow the progression down and help maintain independence as long as possible, so delay the progression of the disease. The cause of, and I do get a little bit sciencey in here, I do nerd out a little bit, but the cause of Parkinson's is loss of dopamine, which is a chemical in our body, in a very specific part of the body, the basal ganglia of the brain. And unfortunately, by the time somebody is diagnosed with Parkinson's, they've typically lost at least 50% or more of these dopamine-producing cells. And we're going to talk about this dopamine a lot because it's not only responsible for how people move, it's also responsible for how people think and feel. And I think sometimes those symptoms get overlooked in a Parkinson's diagnosis. So as I mentioned, the basal ganglia is the very small part of the brain that's affected by Parkinson's disease. And you'll notice that there are 3 circuits that travel through this special part of the brain. There are motor circuits that are going to be responsible for how people walk, how coordinated their balance is, how stiff and rigid they might be, okay? There are cognitive circuits, and these will affect their ability to make decisions, okay? So it'll affect memory, it'll affect ability to memorize the order of how to do something, it'll affect problem solving. It's called executive function. All these little areas all fall into that. This circuit gets affected by Parkinson's. And your emotional circuits, these are the circuits that give us joy, that give us pleasure, that motivate us to do things. This circuit is also affected by Parkinson's. So sometimes I'll have loved ones come up to me and just say, my spouse just sits in the recliner all day long and they don't want to do anything. And they get mad at him when they truly don't understand that that's a symptom of the Parkinson's. And once people begin to understand that, then the blame goes away, and then there's a different mindset around how you interact with that person. So somebody who was an avid golfer or avid gardener, or looked forward to nothing but walking their dog every day, that now you can't motivate to get out of the recliner, it's not their fault. Okay, it's truly that a pathway in their brain that used to motivate them and excite them is no longer giving the right chemicals, and so it's really hard to manage. So when we talk about the motor symptoms in particular, these are going to be the typical Parkinson's presentation. So you're going to see something like a stooped over posture, okay? A lot of that have that as we age, but this is probably going to be even more pronounced, where the head's going to shift forward, the shoulders are going to be rounded, okay? Shuffling of gait means that they're not really picking their feet up anymore. Those feet are still moving forward, but they never really leave the ground. Freezing of gait, this is where the feet don't move at all. So this is a really hard symptom to manage. It typically pops up the longer you have Parkinson's disease, later in the progression, but this will be that somebody's trying to move and the legs don't go anywhere. They can't make forward progression even though their brain is telling them to. We see decreased arm swing, so when somebody walks with Parkinson's, their arms are right down at their sides. With normal walking, your opposite arm and leg should kind of go forward, and that helps you balance. So when your arms get locked down at your side when you walk, you actually start to lose your balance just because of that. We see complaints of difficulty getting out of a chair, difficulty turning in the bed, complaints of morning stiffness, mostly because you've been all night long without your medicine that helps you move. Most people take their last dose of Parkinson's medication around 6 or 7 p.m., and then by the time you wake up at 7 a.m., 12 hours later, your body has been without another dose of Parkinson's meds, and so sometimes the morning routine is the most difficult part of the day. So other motor symptoms we see is lack of facial expression. It's called a masked face, where even if somebody had just heard the most hysterical joke, or they saw the most moving thing in a TV or commercials get me now these days, they'll feel it on the inside, but it doesn't show up on their face. And so sometimes that leads to less engagement in conversation. They start to feel left out, they start to isolate, they start to withdraw. We hear problems of low voice, so that the volume is harder to hear. Most people still have the ability to project their voice. They just have to think really hard and be very intentional about getting that louder voice. We also see things with difficulty speaking. So Parkinson's affects the coordination of all of the muscles in your body, including the muscles it takes to talk. So sometimes enunciating words will become difficult, as well as swallowing issues. We see micrographia, which is smallness of handwriting, and sometimes people will look back and realize that this was one of the first Parkinson's symptoms they had, that they start out a sentence at nice big letters, and by the time they get to the end of it, you can barely see any height in the letters. And then painful foot cramps. Again, one of the hallmark symptoms of Parkinson's is poor coordination. And so if I need to bend my arm, I need to turn on my bicep and turn off my tricep, the muscle in the back. If they both turn on at the same time, because my body can't figure out how to turn the other one off, that's where the stiffness, the rigidity happens. And we see it oftentimes in the feet, especially at night. People will end up with these really painful foot cramps. But if they extend it to during the day, then it's harder to stand and walk because the muscles can't figure out how to turn on and off, the timing's all off. So when we talk about those non-motor symptoms, these are the symptoms that are going to be affected by the cognitive and the emotional pathways that we talked about. So depression and anxiety, these are a symptom of the Parkinson's disease because of the part of the brain that's affected and no longer has that dopamine. Lack of motivation or excitement, I mentioned this earlier. Low energy and fatigue. I hear this all the time too. My spouse used to be on the go all the time, go, 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 and now we do one thing and they're exhausted. This is because the dopamine highlights, it fuels the mitochondria, our energy cells, and when we don't have that fuel, the energy part of our cell doesn't make energy, they lose it. Decreased attention, so ability to focus. Again, this is all with that executive functioning or those cognitive symptoms. We do see memory issues and dementia are much more common, especially the longer you've had the disease process. And then we see other body systems start to be affected as well. So people can have really low blood pressure. We typically see that first. Somebody that was on high blood pressure medication before their Parkinson's diagnosis might need to come off of it. So we might need to monitor that blood pressure to help them get off of it. We see people that will drop really low and they have what's called orthostatics. Has anybody heard of that? Orthostatic hypotension? It's where I would go from sitting and I would stand up and my blood pressure drops so I feel lightheaded or dizzy. Typically, if I go from sitting to standing, my blood pressure will stay the same or it'll even go up a little bit. So this is a not normal reaction to a change in position, and it results in lightheadedness and dizziness. This can be a complicated symptom to manage. On the flip side, we see some people who go from super high to super low to super high all within a single day. And again, it's because that part of your brain is also responsible for managing some of these normal automatic systems. Constipation is very common in people living with Parkinson's. Again, your body just doesn't slow down with your muscles, but everything in your gut slows down too. And if you're moving less, that'll complicate it even further. So we deal a lot with constipation issues, as well as sleep disturbances. So people with Parkinson's not only have trouble falling asleep, but they have trouble staying asleep once they've fallen asleep. And if you don't sleep well at night, you're not going to have energy during the day, and it kind of becomes a vicious cycle. So, how do we take care of all of these symptoms? And by the way, if you're someone with Parkinson's, you might only have 2 of those symptoms that I laundry listed, or you might have all of them but 2. You might have some of them some days and not the other days. So it really does depend on the individual person which one of those laundry list of symptoms you'll be experiencing. But the gold standard for treatment is levodopa. They pair it with another medication, carbidopa, because it helps the body to absorb it quicker, and the brand name is Cinnamate. So most people are on Cinnamate or carbidopa levodopa. It is the gold standard treatment for traditional Parkinson's, okay? Now, if you respond really well to the medications, there is a surgical option. So deep brain stimulation is where they implant an electrode into your brain to stimulate the part of the brain that's no longer making dopamine. It takes place of some of the medication. So folks that have DBS surgery successfully are able to decrease the amount of medication they take. They typically don't get to get off all of the medication, but you can decrease some of the medication. Okay? And when I started PT, treating this population, those were the only 2 treatments that were even considered. Nowadays, though, we've got exercise, which absolutely makes me so happy. And this is what we're going to spend most of the rest of the time talking about. So, in the past, exercise was considered helpful. Like if you went to your neurologist, you got a Parkinson's diagnosis, you asked them, should I be exercising? They'd be like, sure, if you want to. But it wasn't highly stressed or encouraged because we didn't know how valuable it was. Typically, let's say 20, 30 years ago, you get the Parkinson's diagnosis, they're telling you to get your orders in a fair. They're not telling you to exercise and plan for life, okay? So now exercise is considered to be one of the top treatments recommended to help slow the progression of the disease and help you maintain and improve your quality of life. So with that being said, not all exercise is the same. In particular for folks living with Parkinson's, it has to be considered vigorous, okay? I bolded that. It has to be vigorous. So what does vigorous mean? Light exercise, you're walking, you're not breaking a sweat. You could probably sing row, row, row your boat if you wanted to, and you could have a lovely conversation with the person you're exercising next to. That's light. So that might be walking down the hall. Moderate activity, which is one step up, is that you're huffing and puffing hard enough that you would no longer have the breath power to sing a song, but you would still be able to exercise next to the person with you and hold on a pretty decent conversation. You might break a sweat, you might feel like your heart rate is going up. Vigorous activity is that you're working so hard that you can only say 2 to 3 words at a time before you have to take another breath in to keep going. So all of your breath power is going towards exercise and not going towards having a conversation or singing a song. So this will get your heart rate up, this will break a sweat, and this is the level of intensity that people need to exercise at to see positive changes with their Parkinson's disease. Okay, so we just went over medications. I love medications for Parkinson's. Even though I'm a PT and I love exercise, you absolutely need both. So what our job is to do is to work with physicians to help find the right balance. You don't want to be under-medicated, but you also don't want to be over-medicated. And we got to find the medicine allows you to move so that you can exercise vigorously to maintain your independence. So sometimes people are underdosed and we'll work with the doctors to get them a little bit more medication so that they actually can move enough to get the exercise. So it's really finding that perfect balance between the two to help people maintain quality of life and independence. So guys, this is my most favorite slide of the entire presentation. This is why I love exercise so much. So if we're going to go through each of these symptoms, and you'll see there's a medication and an exercise column to see which ones treat which symptoms of Parkinson's. So the motor symptoms, again, for somebody with Parkinson's, rigidity is that they're really stiff all the time. Bradykinesia is the slowness of movement and poor coordination, and we see that a lot in loss of balance or trouble with walking, okay? Those are the typical motor symptoms, along with a tremor, right? That's the hallmark symptom. So the gold standard medication, the carbidopa-levodopa, the Sinemet, manages this symptom very effectively. So does exercise, okay? Now if we start going down the list to some of the other common symptoms of Parkinson's, we have the emotional symptoms, the depression, the anxiety, the apathy. And that apathy is total lack of motivation, of excitement, of joy in life. Carbidopa-levodopa does not help people to manage that symptom, but exercise does. Okay? Now, there are medications for depression, for anxiety. There's not really too many good ones for apathy, for total lack of motivation. Okay? But then we start adding more and more medications. Who here loves taking pills all day long? Anybody? Nobody? Okay, so I'm going to drive my point home. So, cognitive. So this is your ability to pay attention, your ability to problem solve, your ability to recall, your ability to do all these fun executive functions which allow you to function in your day-to-day life. Carbidopa-levodopa does not manage this symptom. Now, there are medications for memory out there. There's a couple of different classes. But again, this is adding more medications, or you can just add exercise. The last group of symptoms is these autonomic symptoms. So these things that happen automatically in our body without even thinking about them. Our ability to fall asleep and stay asleep, our ability to have regular bowel movements and not be constipated all the time, and pain, okay? So like those painful foot cramps of muscles just turning on and not turning off is called dystonia. That happens the longer you have the disease. Again, there are medications for sleep. There's medications for constipation. There's a plethora of medications for pain. But every symptom, you start adding more and more medications to the management, or you can choose exercise. This is why I love exercise, but again, it has to be the right kind of exercise in order to be beneficial. So, I like to share evidence. This isn't just Dr. Beth's opinion, and I like to share some research that's out there to kind of prove the point. So one study followed people over a 2-year period and asked them a simple question: do you exercise at least 2.5 hours a week? Okay, so they looked at people at time point 0. They looked at them at year 1, and they looked at them at year 2. Okay, and they asked this simple question. So if somebody was not exercising at the beginning, at year 1 they were still not exercising, and at year 2 they still weren't exercising, these are the people that experienced the typical expectation of every year your symptoms get worse, every year you lose your independence, every year you're on more medication. Okay, and that's what's considered to be the standard progression without treatment. Okay, now if somebody was not exercising and then they got their Parkinson's diagnosis and they found a great physical therapist and they started exercising, and then at year 1 they were exercising, and at year 2, these people maintained their quality of life and saw almost no change in the progression over a 2-year period, which means they effectively hit pause button on the progression of the disease. Same thing with somebody who was already exercising when they got that diagnosis. They continue to maintain their quality of life and slow the progression of the disease. So what I like to tell people is, even if you have a Parkinson's diagnosis today and you're not currently participating in vigorous exercise, it's not too late. At any point in the journey, you can choose to add that in and can slow the progression and maintain your quality of life. For people who haven't been exercising, we actually see them regain a lot of the function that they've lost. We worked with one gentleman who was not able to put on his shoes. His wife had to put on his shoes and tie his shoes, and he was having trouble getting dressed, getting meals for himself, all of those things. And we worked with him 3 times a week, and then he was independent with all of those things again. His wife left us because she was no longer the caregiver. She then got to be the wife again because she wasn't having to do all of these things for him. So again, it doesn't matter if you're not currently exercising, but the research did show the sooner you start after the diagnosis, the better. So then people will say, okay, so get it, Beth, I gotta exercise. How many days a week do I have to? And I say, how many days a week do you get to? But what the research shows is that there is a threshold of kind of when the benefits start. So the Pro-PD measures the burden of disease, or how difficult it is to live with disease. As the numbers get more negative, that means they're actually more independent. So we like those big negative numbers on this one. So they found that if you exercised 0 days a week, obviously there was no benefit. Even if you got out and exercised 1 or 2 days a week, you really weren't seeing a big benefit to all that work you were doing. The threshold is a minimum of 3 days a week. So why is that? When you look at the World Health Organization guidelines, they do recommend 3 days a week. But people living with Parkinson's are not only fighting against the normal changes of aging, you're fighting against a progressive disease that's going to get worse every year. So it's kind of like accelerated aging. So we recommend a minimum of 3 days a week of exercise at this high intensity level, because the research tells us once you hit that threshold, you really start to see major improvements. But you'll see the improvements, so the numbers keep getting even more negative with every additional day of exercise. So for most of our folks, we want them exercising 5 to 7 days a week. It is a full-time job, but it's better than taking a bunch of pills. So that's just exercise in general. Now we're going to talk about physical therapy specifically. So again, in the past, when somebody got a Parkinson's diagnosis, they were never recommended to get a PT on their team until they had a fall. So here's your Parkinson's diagnosis, get your affairs in order. Oh, you had a fall? Well, now we'll let you see the PT. Now the mindset is much different, and we're seeing people, we are the first stop after getting that Parkinson's diagnosis. They get the diagnosis, and then they say, go see your Parkinson's PT. And some people will come in and say, I just got this diagnosis last week, I have no idea why the doctor wants me here already. But by the time you've gotten a diagnosis, you've already experienced some of those physical changes in order to get the diagnosis. So we can pick up quickly on what you've lost, identify the problem areas, if you will, and give you a couple of activities to get you back on track. Okay? Or if you were maybe further along before you actually get the diagnosis because they were ruling out something else and you had a bunch of other medical stuff going on, then you might need a bigger tune-up. But now the gold standard is that you get that Parkinson's diagnosis and you're sent immediately to a Parkinson-specific PT so we can get our hands and eyes on you and give you a good routine to get started. So again, people will say, well, how often do I have to come? So we have a lot of people that are newly diagnosed, that are still working, that are still pretty high level. We still want to see them every single year, at least for an assessment to make sure things are going okay. And this is why. So they did this great study over in Europe where they did high intensity rehab for people 1 time a year. They got 3 hours a day of physical therapy, occupational therapy, and speech therapy, 5 days a week for 4 weeks. They got a total of 60 hours of specialized therapy in a month. And then they came back a year later. So the people, and they compared this to people who didn't get any intervention whatsoever. So you'll see this is our time point 0. This is the baseline that everybody was on the same amount of medication. Now the people that did not go through the intervention, so that saw that and experienced the normal progression of Parkinson's, you can see at 6 months they needed more medication. At 12 months, they needed more medication. Same thing at 18 and 24. As the disease gets worse, you need more of that medication to manage the symptoms. Interestingly, when you compared it to the people that went through this intensive rehab once a year, at 6 months, no change in medication. At 12 months, no change. They had stalled the progression of the disease. Now, they did see a little uptick at 18 and 24 months, but that's a significant decrease compared to the group that got no intervention. So this just shows us how powerful physical therapy, occupational therapy, and speech therapy, you probably need to see all three, can be to delay the progression of the disease. Because we know you only need more medication when the symptoms get worse, meaning that the disease has gotten worse. So again, I'm going to go back to these 3 circuits. Your motor circuit, your cognitive, and your emotional circuit that all run through that part of the brain, the basal ganglia. So a Parkinson-specific exercise, we throw this term around all the time in PT. It has to be specific to Parkinson's. What does that mean? It has to light up all 3 circuits at the same time. If you're only lighting up one, you're missing, kind of the best part of the exercise. So I have one guy that tells me, that's a runner. He's like, Beth, I run 5 miles a day. I don't need your intense exercise. I said, that's great. You are fulfilling your motor circuit, but let's talk about how you're fulfilling your cognitive and your emotional circuit while you're doing that. And we couldn't figure out a way. So he needed the Parkinson-specific exercise. So the motor circuits have to tackle the hardest symptoms of Parkinson's, and that is the stooped posture, the slowness of movement, the poor coordination. So if the exercise isn't specifically addressing those 3 things at a high intensity to where you're huffing and puffing and breaking a sweat, it's not a Parkinson-specific exercise. Okay? For the cognitive circuits, what that means is it also has to be mentally challenging. You have to be using your brain while you're moving your body. Okay? So sometimes as therapists will layer in a thinking challenge with a moving challenge. Let's go ahead and do one together. So you guys can stay seated, but I want you guys to just march in place with me, okay? I'm gonna get the blood flowing. Okay, so this is our movement challenge. Now we're gonna add a thinking challenge. I'm gonna give you 3 numbers, and I want you to tell them to be backwards. So if I say 1, 2, 3, you would say 3, 2, 1. Okay, so 9, 3, 8. Good. 4, 9, 2. That one was okay. 7, 4, 1. Good. 8, 6, 2. Okay, now we're going to go for 4 numbers. 8, 3, 1, 9. Ooh, 7, 4, 2, 6. 9, 3, 2, 4. Good, and relax. So, if I gave you the same thinking challenge while your body wasn't moving, you probably would have done better. But because we're making you think and maintain that movement, it becomes a more complicated task. Okay, so it has to challenge that cognitive circuit. And then for the emotional circuit, it has to bring you joy or laughter or make you laugh or just be silly. It has to get you wanting to come back. So part of it is that we do a lot of fun things, like I heard some giggles and saw some smiles just during that simple activity. But there are a whole group of exercises called power moves, which we'll talk about in another slide or two, but it really gets you to do fun things. We box with all of our people living with Parkinson's. So as a coach for Rock Steady Boxing, and all of my therapy team has been cross-trained in boxing, and there's so many great benefits to that, in that it's high intensity. It takes a lot of coordination, it takes a lot of thinking to follow the punches, and it's something novel. We have women who are 86 showing up with their hot pink boxing gloves, and they get to tell their grandkids, I'm gonna go boxing. And it's pretty darn cool, right? We do it, so again, it has to highlight, to be a Parkinson-specific exercise, it needs to highlight all 3 circuits, okay? So power moves. This is a Parkinson's-specific program in the physical therapy world. It stands for Parkinson's Wellness Recovery, and the shortness is POWER, PWR, exclamation point. So this routine was, this concept was developed by Dr. Becky Farley, who's one of the leading physical therapists in the Parkinson's world. She helped develop another program called LSVT Big. Has anybody heard of LSVT? Great. So this was considered to be the gold standard treatment for people living with Parkinson's, and it's still an amazing program, but it's very regimented. You go 4 times a week for 4 weeks and you're done. That's it. Yep. Power moves. She kind of took what she learned from doing this LSVT program and she put it on steroids. It's kind of the next level. So our entire team is certified in these power moves, but it's designed to overcome the most common and debilitating symptoms of people living with Parkinson's. There's 4 different moves that we can do in 5 different positions. So we can do exercises standing, sitting, on your hands and knees like you're in a crawling position, on your belly, and on your back. So it gives us 20 different exercises to prescribe. And we might go through and find that 10 of them are easy and don't really challenge you, but the other 10 sure do. And those are the ones that you're going to work on. So it's really fantastic. And we're the only clinic in St. Louis to have our entire team certified, which I'm really proud of because we love working with Parkinson's so much. And it's really been a game changer for helping us get even better outcomes for our clients. So lots of information today, guys. But if you're someone living with Parkinson's, this is kind of what the research has published as how to get the best outcomes of managing your disease long term. You need to see a movement disorder specialist. Does anybody here have a movement disorder specialist? See, good. So a movement disorder specialist is a neurologist with additional training specifically in diseases like Parkinson's. Okay? When you first get that diagnosis, a neurologist is great, but particularly as you have the disease longer and you start to get more and more of all those symptoms off the list, and the medication becomes a little more complicated because now you're on a couple of different ones to help manage your symptoms, having a movement disorder specialist, people have better outcomes when they have that person on their team. Now, you can keep your regular neurologist as well. Some people like to have both because the neurologists are a little more accessible than the movement disorders clinics. But we do recommend that if you don't yet have a movement disorder specialist, you get on the list. And the wait list is anywhere from 12 to 18 months right now. There's not enough of them to go around. The second recommendation is to work with a Parkinson's specific therapist. If your therapist does not have LSVT or power training, you might want to find another therapist because I don't think they fully understand the best ways to help you manage those symptoms long term. So we would encourage you to find either somebody with LSVT or power. You have to have a program specific to your problem areas. This is why we want to see people in as soon as possible and why we want to see them every year. If you come in a year later, you might have different symptoms that kind of have cropped up in the past year that didn't exist a year ago. And we might need to tweak your exercise program. So there's no custom one-size-fits-all program for Parkinson's. It's really selecting the best exercises from like a Power Moves program, kind of looking at your daily activities, what you're struggling with, and giving you some things to manage that as well. You need ongoing program and support. Again, this is why we see our folks at least every year. Some of our more advanced folks will check on every 6 months, just to make sure that they're not progressing quickly. And then the recommendation is to add exercise as early as possible. So again, if you're not exercising today, that's okay. We'll give you the day off, but you can start tomorrow, okay? So there's a phrase out there, there's actually a movement out there called exercise is medicine, and I think it couldn't be more appropriate than particularly with this diagnosis. So it has the benefits of medication with all of the side effects. Once you start taking more than 4 medications, is anybody here on more than 4 medications? Don't be shy. Most of us probably are. You start getting into what's called polypharmacy, to where one medication starts interacting with another medication, and then you have a side effect from one medication, and so you take another medication to manage the side effect from the first medication, and then the laundry list starts to add up, okay? So exercise has all of the benefits of medication, especially with Parkinson's disease, without all the side effects. And exercise can actually help reduce the need for medication. So we don't typically help people wean off of their Parkinson's meds, but with exercise, we've been able to get people off of their blood pressure medicine, their diabetes medicine, their cholesterol medicine, their insomnia medicine, their constipation medicine, their pain medicine. So we don't usually get you off of your Parkinson's meds, but with the exercise, we can get you off of all the other guys and just decrease the number of pills you're taking a day. Exercise absolutely delays the progression of disease. The research shows that effectively, that if you exercise on a regular basis, at least 3 days a week, high intensity, you will kind of hit the pause button on the progression. And if you haven't exercised in a while, you will actually regain some of your independence by doing so. We love exercise because it manages just more than just the motor symptoms, okay? We're looking at all the cognitive, all the emotional, all those autonomic symptoms that can sometimes be more problematic than the traditional Parkinson's symptoms themselves. Exercise helps improve quality of life, but it has to be specific to the issues you're having, and it has to be at high intensity. Now, some people will say, Beth, how do you possibly think it's safe to exercise people at high intensity at your age? Okay, but we're therapists, so we check blood pressure, we check heart rate every single visit to make sure that you're safe. And your level of vigorous might be different than your level of vigorous, so we figure that out for each person. And if you haven't exercised in a while, we start, and then we just keep building up week after week to get you to that point where you're getting all the benefits. So for those of you who don't know much about HouseFit, that is the physical therapy clinic that I own. We are a specialty geriatric clinic, only working with folks 55 and older. And again, about 40% of the people we work with have Parkinson's disease. So we focus on the physical health and wellness of aging adults, and particularly those living with Parkinson's. Again, we believe that you can always improve physical health and independence, and our goal is to educate our patients so that they can make better decisions about kind of the course and the choices that they make. So we do have a gym down in South County. We offer one-on-one therapy there. We offer private training sessions. The power moves exercises that I mentioned, if you come to us for physical therapy, you're going to be introduced to power moves. We're going to figure out the ones that are the best fit for you, give you a home exercise program. Some people really struggle with doing that home exercise program. Has anybody ever been on therapy before? Are you still doing your therapy exercises? Yes. Oh, good. I got some yes and some not so muches, okay? But what we see is that sometimes it's hard to motivate yourself to exercise at that intensity level ongoing. So we took all of the power moves and we put them into a class that one of our physical therapists teach twice a week. And we also have our small group training program, which I think I have a video of, just to kind of show you what high intensity looks like for older adults. And I know you guys are not near South County, but we do have a mobile therapy team. Some of you guys know Sandy. Sandy's in and out of the building all the time. So she works for HouseFit, is trained in power moves, and we can deliver the services here. You do not have to come down to see us in South County. So our power moves class, we limit it to 10 people, and we make you get up and down off of the floor every single visit, every single class. So if you can't do that yet, that's a good reason to seek out therapy. But I just want to show a short video. Let's see if it'll work. So this is Tanya. She's our favorite power moves trainer. But everybody gets a chair, everybody gets a mat. We work on all 4 positions, or all 5 positions, work on back, belly, hands and knees, sitting, standing throughout the course of the class. And not everybody in this class has Parkinson's. Some people just kept looking over the half wall and say, well, that class looks fun, can I join? And we said, sure. But the majority of the folks in this class do have Parkinson's, I'd say over 50%. So we do offer that class. And then we also offer a small group training. We limit this to 5 people, but it's my most favorite class that we offer because it focuses on high intensity in both cardio, strength, and endurance. So this is a fun one that we offer. And again, a lot of people, I would say every single one of our groups of 5 has 1 or 2 people with Parkinson's in there. But here we get to pull in all the boxing equipment. So we do boxing every time. We will do agility ladders, hurdles. We will lift the heavy kettlebells, the medicine balls. But like the average age in this group is probably 78. She's had a stroke. He had a hip replacement. She's had her knees done. He's had a shoulder. So this is what a high intensity exercise can look like into your 70s and 80s, even with all the medical history and other things going on. So again, this class we get up and down off of the floor, but we do have modifications for this level if you can't get up and down, just because we can give you a little bit more of that individualized attention. So this is vigorous exercise. If this doesn't look like what you're doing in your exercise classes, you're probably getting some good light to moderate, but we're missing that vigorous, okay? So, if you're interested at all at working with us to help manage your Parkinson's or anything else that you have going on with your aging, we offer a free consultation, a free assessment. So we do those down at the gym, but we also offer them out in the community. So we can come here, we spend half an hour with you, with one of our therapists. We find out what's been going on, what you're struggling with, what the goals are, and we'll actually do some testing to figure out how good or not so good things are. That way we can make a recommendation. I will tell you that if you're interested in therapy, we're going to recommend 3 times a week to start, because that's what the research tells us is the best practice. You might say, I can only do 2, but we'll have a good conversation about it before we agree to 2 times a week, okay? But we do offer that. If you're interested in that, I would call today or tomorrow, because we're on a little bit of a wait list to get out for those assessments. We've just been really, really busy this summer, which is fantastic. Other information that we do have back there, so you guys all have one of our brochures and our monthly newsletter. So we just printed out copies of it. If you want to get on the monthly newsletter, we've got a clipboard back there so you can sign up, and we just mail it out once a month to the house. We do have 2 guides specific to Parkinson's. One is kind of a summary, the Cliff Notes version, if you will, of today's presentation, Parkinson's and exercise. The other one is specifically about the symptom of freezing of gait. So freezing is one of the most challenging symptoms to manage, and so we've written a whole guide on it with a bunch of tips and tricks that you can use in home. Yes, sir?
Could you repeat the description?
Yeah.
The words didn't come through clearly.
Yeah, the description of the newsletter or the guide?
Something about gates.
Freezing of gait. So that's where you try to walk and your feet get stuck to the ground. So freezing is a symptom of Parkinson's. It can be very challenging to manage, and it takes like a whole nother set of skills and tips and tricks to kind of figure out. A lot of people will freeze when they walk through a doorway. They will walk when they're trying to turn to like a chair. We kind of get stuck, and then we do the crash landing, leading with the butt, right? And then starting and stopping. So there's a Parkinson's and exercise guide that will review the information we covered today. And then there's a freezing of gait. So if you're having trouble with starting to walk, trouble with turns, trouble with doorways, that might be something that you want to get that one as well. But there's sign-up sheets for those things in the back. And I will open it up for any other questions. Yes, sir?
Is it genetic? Tied to genetic?
Yeah, so the question is Parkinson's genetic? Some of it is. So some of it is familial and is inherited. Most Parkinson's is considered to be idiopathic, meaning they don't know the cause. The most popular theories for what triggers Parkinson's are exposure to certain pollutants, like pesticide and chemicals. So if you were in certain careers that may have exposed you to pesticides, I think in certain things like not x-ray, like foot copying places, like things that had a lot of chemical smells in them probably predisposed you to that. They've also found a huge link in the past 5 to 10 years about gut health. And so they think that Parkinson's starts in the gut and works its way up to the brain. So there's a lot of stuff now about diet and trying to remove, so if you're on a Parkinson's diet, the recommendation is no meat, no dairy, no eggs. Yeah, so I've been vegan since January, it's not that bad. Does that help? Yes?
Is it difficult to diagnose Parkinson's? I've heard that it is.
I think the question is it difficult to diagnose Parkinson's? I think it depends on the symptoms you have. I think some symptoms are more obvious than others, like the tremor. 70% of people living with Parkinson's have a tremor, and that's the first symptom they have to trigger the diagnosis. Other people do get misdiagnosed, or they have to wait. It's like a diagnosis of exclusion. So sometimes they have the best confirmation of the diagnosis when they put you on the Cinnamon and your symptoms go away. If they put you on the Cinnamon and your symptoms don't get better, you probably don't have Parkinson's. Or it probably, so that's, yeah. So it is challenging, I think. I think it depends on how body aware you are. So, and again, some people brush this stuff off as, I'm a little stooped over, I'm walking a little slower, I'm having trouble getting out of a chair, I'm just getting older. So people brush off the symptoms as a part of normal aging instead of looking for an underlying cause of something else that might be causing it. Yes?
It seems that Parkinson's is more prominent in males. Is that true?
The question is Parkinson's more prominent in males? And the answer is yes. The other big cause for it is things like Agent Orange. So we see a lot of our Vietnam vets that are developing Parkinson's. So Agent Orange, pesticides. So in the Rust Belt, there is a higher incidence of Parkinson's because of all of the farming industry that we do. There are other areas of the continent in the world that don't have as high of an incidence. So they find where there's a lot of industries, a lot of steel, a lot of manufacturing, a lot of agriculture with a lot of chemicals and pesticides, the incidence is higher. It is higher in males, and our war vets have a higher incidence as well. Yes?
On the intensity of the class exercise, like how long is it? Is the intensity really high up? I mean, is heart rate up?
Yeah. So the question is how long do I have to exercise that hard? So we focus on what's known as interval training. So it can be called interval training, it can be called HIIT, high intensity interval training. So depending on where you start, your high intensity might be 30 seconds and 2 minutes of rest. That might be where we start. Can we do something really hard and really challenging for 30 seconds? And it's gonna be the longest 30 seconds of your life. And you get 2 minutes to recover. Now in the classes, once you get to the classes, we typically do that high intensity for 2 minutes and we rest for 30. So that's the goal, is to kind of build up to 2 minutes of high intensity exercise, having 30 seconds to recover, and then turning it back on. But that's not where everybody starts. So it is dependent on the person and their fitness level when they start in with the therapy. Yes, sir?
How do you tell the difference between an injury, for example, a knee that goes back 30 years and Parkinson's?
Oh, so just a knee injury versus Parkinson's. So the knee injury would be very specific, like isolated to the knee, whereas Parkinson's is going to affect your whole body. It typically affects one side of your body to start. The longer you have it, then you're going to see the symptoms on the other side. But if you go to a good neurologist, they'll do cogwheel testing, so see how fast they can move the joint. They're going to do coordination drills, so flipping back and forth. They're going to do nose to finger. They're going to watch you walk forward and backward. They're going to do a pull test to pull you off balance backwards. So there is a lot of diagnostic tests that go into that, and somebody with just a regular old knee problem won't have that. Now, can you have an old knee and then develop Parkinson's? Absolutely. Most of the folks we see with Parkinson's also have diabetes or have spinal stenosis or have big balance issues. They usually don't come to us specifically just for Parkinson's because you have all that other medical history kind of coming along with you. Good, yes, sir?
We have a 45-minute water aerobics every week,
Yeah.
3 times. How do we tell if that's sufficient for the high intensity?
So there's a water aerobics class that's 45 minutes. How do we tell about intensity? It's really that talk test. So if you're in class and you could hold a conversation with the instructor, it's not high enough intensity. If you really feel like you're huffing and puffing during that class, you're probably hitting it. And again, you could have 10 people in that class, and for 2, it's really easy. For the middle 6, it's kind of moderate, and for 2, it's high intensity. So you can kind of have everybody doing the exact same routine, but based on your fitness level, it'll be a different impact for you. So we call it the talk test. So if you can say a sentence and not need to catch your breath, so you're probably at moderate. So try to push yourself a little bit harder. And not necessarily for the full 30-minute class, that's not reasonable. But can you pick one exercise that's really hard and try to push yourself for that one, and then let your body kind of calm down, and then push yourself a little bit harder. But that's something that's hard to kind of self-police, which is why taking a class with an instructor that focuses on it is good, or working one-on-one with a therapist to kind of give you that skill set and help you think this is what high intensity feels like versus this is what moderate intensity feels like. You do start to learn your body's reaction. Yes.
I just have something to share, and some of you know about this, but excuse me. My husband has Parkinson's. He was diagnosed in 2015. He probably had 3 or 4 years before that. We went to 3 neurologists in the St. Louis area before 2015, and they all dismissed his symptoms. He did not have tremors. He's one of those unusual people that don't have the tremors, and severe balance issues. And the last neurologist at St. Luke's, who was very, very highly recommended, said, you don't need to come back unless you want to. We happened to accidentally make a miracle with a orthopedic doctor that he was seeing for a ruptured Achilles tendon. And we got into very quickly, because there was a cancellation, she got us into the movement disorder clinic. We've also been to Gainesville, where they were much more advanced than we were in the St. Louis area. They were gold standards place for years ago. And also went through the Power Move stuff and the LG whatever in Florida years ago, before it ever made it here. But anyway, back to the 2015. We went down to the movement disorder clinic, and I had all my records. I had the CAT scans, the MRIs, everything, big stack of stuff. And the doc said, I don't need to see any of that stuff. And within a few minutes, he said, he's got Parkinson's. So we've been on that journey with the neurologist down there, movement disorder guy, since 2015, and it has been a wonderful experience.
Good.
I just want people to know that, because we were very frustrated for a while. Me more than Norb, he was ready to give up, but anyway, it was a very good experience.
Yeah, but like I said, usually by the time you get the diagnosis, you do the look back, and you're like, oh, that was Parkinson's. Oh, that was Parkinson's. Well, that was Parkinson's too, which is why you should see the PT right away. But yes, people will often look back, and then everything kind of falls into place of, well, this is why this was so hard.
Norb always complained about having trouble turning over in bed. I mean, 20, 30 years ago, 40 years ago maybe. And once we knew the diagnosis, we realized, hey, that was part of Parkinson's.
That was the rigidity setting in.
Yeah, so it's real important to get a diagnosis and to get somebody to monitor you that really knows the disease, in my opinion. And to get a good therapist, by the way. Kudos to Sandy.
Oh.
She's wonderful. I really do believe that Norb's symptoms have plateaued to the point where I can still assist him at home because of the therapy he's gotten.
Wonderful.
Specific to his Parkinson's.
Well, thank you for that. But I'm so sorry that you had that journey to begin with. That's unfortunately the modern healthcare system these days, is sometimes people will brush you off. Again, that's why I share that story about ageism at the beginning, because you will get brushed off, ignored. Well, that's a normal part of aging, whether you're dizzy or your knees hurt or you have balance issues. Like, oh, you just have arthritis. Just take some pills. Go and see the pain specialist for an injection. They don't give you the same mindset where if I went in with those same symptoms, I'd get a full workup just because I'm in my 40s and not in my 60s or 70s. So there's so much about needing to be an advocate, building your team around you to get the right neurologist or a movement disorder specialist and a PT and an OT and a speech therapist. You're probably going to need all of them, and you should find somebody that has Parkinson's specific training, because I'm going to pick up on, you know what, you got really bad over the last 4 weeks. That's not normal Parkinson's. I think maybe there's something underlying medical going on. Let's call the doc and see if maybe you have a UTI. Let's see if that pneumonia's back. Let's see if something else is going on, because Parkinson's does not progress this fast. We had a gentleman who had back surgery, and then he kept getting electrical zingers down his leg. And I kept calling the surgeon, and I said, this is not Parkinson's, this is due to his spinal surgery. It's Parkinson's. Kept calling. I called every day for 3 weeks, and then we finally sent him to the ER. They put him on hospice for Parkinson's. And I kept calling his wife. I'm like, this is not right. This symptoms do not manage the speed nor the symptoms of a Parkinson's progression. I believe it in my heart. He is now off of hospice, He's back to walking and boxing with us and all these things because they realized one of the screws was pushing on his spinal cord and they had to go in and do a revision. But they were so willing to put him on hospice because that he had the underlying Parkinson's diagnosis and ignore the back complaints of electrical zingers, which screams in my brain, spinal cord, not Parkinson's. So it can be very frustrating. So that's why I very firmly believe having somebody that understands the normal progression, that can help you differentiate between a true progression of the disease and a need for a medication adjustment versus there's something else going on medical underlying that needs to be addressed. It does really make a difference. Good. Any other questions I can answer for you guys today? Yes, ma'am.
Hi, I'm Annie. I work at Mason Point. I work in the assisted living area.
Yeah.
And I'm so proud to say that we are building a boxing ring
Oh, wonderful.
for our Parkinson's guests.
Fabulous.
You know, and everything you said, Beth, has just been terrific, but I do have a bone to pick with you because
yes.
Sandy Paris used to work here first, and you took her, and we're so happy. I did a referral with her today
Oh, good.
for a new gentleman that I'm working with. So wonderful. Kudos to you. Kudos for everything you do. I also want you to know that we parallel with ALS. ALS is one of a disease, an association that refers to Mason Point because we have such great outcomes.
Yeah.
And I think in our assisted living, our outcomes with our Parkinson's is incredible because our director of assisted living, she knows how timely the medicine is, how important this exercise is. So I just want to let you all know how seriously we take it in assisted living. So thank you, Beth.
You're welcome. And the timing of the medicine is crucial. So sometimes
Crucial.
when somebody's having a bad day, it's just because they missed the dose. Yes, ma'am.
Do we need a referral from a doctor?
Ooh.
And do you take Medicare?
So 2 questions. Do you need a referral from a doctor and do you take Medicare? So if you are wanting to get skilled physical therapy, you do need a doctor's referral. When we come out for that free consultation, we'll get your doctor's information and we'll call and get all the, typically a neurologist or even a primary care will give the order for Parkinson's. We are a Medicare provider, so we do work with Medicare, and so they cover, we bill as a Part B provider, so typically Medicare will cover 80%, and if you have a supplemental or secondary, they would cover the other 20% copay, as long as you've met your deductible for the year.
Do you take any other insurances, just straight Medicare?
We take straight Medicare, and we work with the Medicare Advantage plans that are PPOs. The HMOs don't, since we're not contracted with them, they don't play in the sandbox with us. So, but the Medicare Advantage plans will, and some people still have commercial plans through spouses or just through really good retirements. So as long as they're PPOs, we can work with those as well. All right, guys. Well, I will, if you want any of the information, please sign up for it. Otherwise, I will stay around for a couple of minutes in case you had a question. You didn't want to ask in front of the room, but thank you so much for your time today.